Hello, everyone. I'm just going to give it a couple minutes for people to log in, and then we'll get started.
Okay, folks, thank you all for being here and tolerating me being the moderator. So, question one that we have is innovation requires flexible, intentional leadership. What best practices can you share that have allowed you to strike an effective balance between managing strategic initiatives, caring for caregivers, and prioritizing patient outcomes and experience? Anybody want to be the guinea pig and get us kicked off with that question?
I can start at Houston Methodist. My name is Scott Ulrich, Houston Methodist Hospital. We had an intentional vision questing approach to innovation about 7 years ago, getting together with groups of operational leaders and physicians and other clinicians and talking through what innovation might look like in the healthcare space. We migrated that into kind of like a study group, which we called DIOP, Digitally Innovative Obsessed People, which then became more formalized into a Center for Innovation. We have a Chief Innovation Officer for our system who is responsible for shepherding the ideas and bringing them forth into the Center for Innovation. Center for Innovation is separately funded so that it's able to take new ideas and new products and quickly bring them to test or pilot phases. And then the Center for Innovation then measures the metrics and determines when they're ready for full deployment.
Thank you, Scott, for sharing that. If no one else wants to jump in right after that, I'm happy to share a little bit about Norton Healthcare. And Norton, obviously, starting with an N, we had something kind of catchy several years ago where we called it innovation, right? And we actually sent this out to the employees. So all about 16,000 at the time. And so you can imagine then getting all that information back and then trying to decipher what does all this mean and then put things into action, put ROIs around them. It was quite challenging. And so I think over time, we've kind of reverted back to being a good leader really is going back to some basics, right? Of being visible, being a good listener, and following up with the team. And I believe that over time of trying to build trust with a tenured nurse or a new Gen X, Y, and Z nurse, they connect with you in different ways and they become loyal and trustworthy in different ways. But they all find some loyalty and trust with that connection. So being able to connect with those folks and taking their ideas and giving them those honest feedback, hey, listen, not going to make the cut this time in X, Y, and Z, Y, but then having those individuals that are really going out and watching the YouTube and having these, I say watching the YouTube, not to pick on them, but those folks that are really looking at all these innovative things and bringing them back to the table, us as an organization really trying to funnel some of those innovative ideas to reality is obviously a challenge that I think we probably all face at some point.
And, I really like that too. I really think as an organization, what we do is we've maintained a balance between innovation and practicality by really setting clear priorities. I think that is so critical because agile strategy with clear priorities is definitely a must, especially when we're looking at innovation, really improving that, because you figure innovation definitely requires flexible, intentional leadership. And our leadership integrates technology with clinical workflows to really ensure innovation enhances patient care without really overwhelming staff. And I think that's really important. I think as a technology leader in a healthcare organization, I mean, we start throwing out tech. We really have to kind of show a specific return of investment on the reasons why we're basically continuing to innovate, continuing to basically transform our overall organization into more of a digital focused industry. Because I've always stated that hospitals and clinics are technology organizations that deliver healthcare services. We're truly living in the digital age of healthcare. And I also think that we have to look at some strategies of really empowerment through technology, utilizing technology to improve better patient care outcomes, improve better ways for our clinicians to basically interact with our patients. I mean, look at the provider burnout rates. That's a major concern. Can we empower technology to reduce those type of burnouts within the organizations? I think by providing consistent communication, support systems, and really wellness initiatives, this really ensures that our caregivers really feel supported, especially directly impacting patient care outcomes and staff satisfaction. Because in the end, I've always stated this, is that if you work in healthcare, you have a new CEO, and your new CEO is the patient. And that's basically the bottom line. We have to look at the patient as the new CEO. Are we as an organization continuing to build asynchronous tools that benefit our patients both inside and outside of the organization? We really need to ask ourselves that too. And the issue though too that I've seen with healthcare as a whole too is that the healthcare industry, unfortunately, has been one of the most antiquated industries out there. But we're doing the most important thing, and that's dealing with patients. That's saving patients. That's enhancing better patient care. We should be leading the pack when it comes to digital transformational initiatives.
Jeremy, so this is really insightful comments for everybody. And I certainly recognize that innovation more often than not involves technology. I mean, I think that's the parallel that people draw. And I mean, our organization is sort of no different. Our innovation group sits in IT. Our CIO is also our chief transformation officer. But at this stage of the game, I mean, we're all Amazon, right? Every company is a technology company, and by extension, every department is a technology department. And so I wonder if transformation and innovation always needs to sit in IT. And Michael, please don't take this the wrong way. Given that healthcare has been such an antiquated industry when it comes to technology, and by the way, all the technology vendors that are out there, I think, have failed healthcare on sort of an exponential level. I mean, we could sort of cast aspersions about the government and regulatory landscape as well, but maybe transformation and innovation doesn't need to sit in IT, because there's certainly other ways to transform your organization. More often than not, technology becomes a part of it. But I'm curious as to whether transformation always sits in IT at the other organizations or in the industry at large.
Jason, you bring up a great point and a great question. And I would say the answer is absolutely not, right? The transformation can sit anywhere in the organization. That certain organizations may have a transformation office that lies within the IT realm, but I don't think it has to. And I can speak from a nursing perspective that we constantly ask our nurses to be innovative alongside their physician colleagues, right? To do these things together in a dyad kind of relationship. That innovation really just means, what are you doing new that hasn't been done at your organization before, right? It doesn't necessarily mean that we're inventing something that hasn't ever been there before, but has it really been innovative? And Jeremy, what I like what you ask about the question, are we really looking at caring for our caregivers and prioritizing patient outcomes? And we as nursing leaders, not nursing leaders, we as healthcare leaders should be asking the question, is this innovation going to drive patient outcomes to the positive? And if it's not, are we doing things just to do things? Or are we, to your point, Jason, are we going to fail yet again in our spaces and not drive improvement in our organization? So I think we continue to have to ask these. And again, one of those best practices is, are we adding one more thing to that unit or to that organization, to that physician, to that nurse, to that respiratory therapist that doesn't need to be added? And are we really seeking out areas that are like ripe for innovation and are excited about innovation and driving them in that space, instead of us telling, as leaders, saying, hey, let's try this piece of code, you do this. Why don't we ask them to say, what is missing in your world? What would you like to be innovative about to do that? And some people have developed that very, very well around the country, right? Around putting different processes in place to really put ideas forward and have them vetted through a place that's going to make a difference. So great topic, great conversation around just this first question. So thank you, Jeremy, for posing it.
And, to add to Jason's comment as well, it shouldn't just lie in IT. This should lie within the entire organization itself. It needs to come from the top down moving forward. But we also have to realize, and depending on what your organization, where you see IT as, but IT is really a backbone of modern innovation, really enabling healthcare organizations to adopt to advanced technologies like what we're doing with artificial intelligence, machine learning, automation, cybersecurity, tools to really revolutionize the enhancements of better patient care and really streamline operations and enhance outcomes. Those are extremely critical components moving forward. I'm not saying that IT is really the center point of everything, but it is definitely a backbone to really drive this industry that has been very antiquated, to really digitalize and to modernize. But again, it starts from top down, and it is an organizational-wide initiative that each member needs to be associated with it to really drive the enhancements of better efficiencies for our clinicians and all our individuals that we basically serve within this organization.
Thank you all. I appreciate the insight there. So these transformations often necessitate shifts in behavior and routines. Can you share some lessons, takeaways, or best practices for driving acceptance, overcoming resistance, and ensuring a smooth transition? Scott, thank you for kicking us off last time. Appreciate that.
Well, I hate to be the one to always kick us off, but I do have an example for this, so I'll jump right in. Necessity is the mother of invention, and we found during the pandemic that we had a lot of necessity. So many of our transformations and innovations came as a result of those experiences, not being able to enter the patient room as often as we would like, not being able to have patient contact in the same way that we did before. And so we started thinking about how we were going to solve for those problems. We created a tele-ICU almost instantly so that we could quickly expand our ICU capacity and allow for safe handling of exponential growth in ICU demand. We then transitioned that, realizing that nurses can't be in the room or shouldn't be in the room with some patients as often as they were used to, and how we were going to monitor those patients and keep them safe, and transitioned into a telenursing concept that we then decided after the pandemic was so valuable that we maintained. And so that was our transformation kind of lesson. We started working with nursing units with the telenursing and determining from them what was the most beneficial elements of this telenursing concept to them, and settled on a few key elements that the telenurses provide for the patient. Some of them are providing admission interviews and discharge training. Others are we are able to monitor patients at a 1 to 100 ratio, so that patients are maintained in a safe environment with algorithms, computer algorithms that highlight patients who are transitioning or becoming more critical than their baseline. We also implemented bio buttons so that each patient is monitored automatically every few seconds for biotrends that feed into that telenursing monitor. We now consider certs to be a failure. Certs used to be the first rescue before codes. We consider certs to be a failure in rescue, and we're able to identify patient trends before a cert is even necessary and intervene to rescue patients. Then the transformation of that is we've been able to work with nursing leaders and do a transformational staffing model, incorporating these technologies into their daily routines, determining what the new safe ratio should be. We were able to change those ratios for both PCAs and nurses based on this tele ability, this monitoring ability. Reduce the number of vital signs, reduce the number of touches that nurses have to make to keep patients safe. It's been a partnership, definitely with the bedside clinical teams and the nursing leadership, but been a very beneficial one throughout the journey. And our patients are safer.
So I'm going to add on to Scott's point, because we've done the same thing throughout all of Providence around looking at our co-caring model, which is our virtual nursing model here to do that. And one of the things that you have to do to overcome resistance is to continue to explain the why and make sure that they understand the why. Why are we doing this? Why are you telling me I have to do it this way? Why are you? And again, in our case, Scott, we had increased ratios, right, to go from to have that, because we're pairing a nurse with a nursing assistant and asking them, how are you going to delegate effectively? Nurses are not used to delegating because they're not used to having enough help on the floor. So they're used to doing everything themselves. So nurses have lost the ability to delegate, in my opinion, because they just don't remember how to do it. They're just used to doing it all. So constantly overcoming the barriers to say, hey, you have a new partner now, right? You actually have two new partners. You have a virtual nurse and you have a nursing assistant that you can partner with in order to get these done, to get your tasks done. But now you can rise to the level of what you were trained to do, RN, in order for you to really go in and assess, really go in to spend time with your patient, really look into the chart and really scan the situation so that you can come up and really prevent, to your point, prevent things from happening right earlier than that they needed to be. So those are things that we have done to really make sure we've overcome barriers and resistance, but also having that smooth transition. Now, do they like it at first? Of course they don't, right? Because nobody likes change. But once you are persistent and keep on and continue to show them the benefit, and they finally, the light switch comes on and they see the benefit, all of a sudden their resistance turns into championing the change. So that's what we have loved to see as well.
Yeah, our rollout was slow for the telenursing process because we were afraid of that resistance. It became a pull strategy rather than a push strategy for us, because nurses started talking with one another and saying, I want this in my unit, and clamoring faster than we could deliver at one point. So yeah, it's been a great transition.
Great success story, both of you.
Yeah, Jeremy, I think less specific examples, but I think more about what I like about this question is routines. And innovation is one of those things that has to get into the routine of an organization. I think, specific to my role, I've said, the greatest value that my team creates is that I give 30 or 40 revenue cycle operations leaders time to think about something that's not happening in the next 5 minutes. And that safe haven that we give them allows them to stop thinking about the exceptions that jade their lens as to how healthcare, and in the specific case, revenue cycle, are supposed to work. So we are routinely creating venue for our operations leaders to think about change and how to do things better. The other thing we do is sort of triangulate that conversation around three things. One, what is the most important thing your staff does? And then we validate that. And if they've got it right, then we ask, does that thing create value? Okay. And we validate that. And then if it creates value, we say, how do we get them to do more of it? And that is what leads us to change. And that change might be a piece of technology, intelligent, automated, otherwise. It might be a reallocation or a reorganization of function. It may be a reallocation of the management model. or the operating procedures, but it's all change. And so we think that that routine helps drive certainly incremental change, and in fewer cases, real transformational change in our revenue cycle.
I also think it's really important to really at least, have open communication with staff to really ensuring them that the transformations and the innovations that we're putting into this organization aren't temporary, but part of the long-term strategy to really just integrate technology into more routine patient care initiatives, which I think is extremely important. And also, in order to be successful at any specific project that you come out with as well, especially when we were looking at really enhancing our overall telehealth initiatives, I had to really look at leveraging data and success metrics. That was extremely important because I was able to share data on patient outcomes and satisfactions to really demonstrate that telehealth was not only effective, but also welcomed by patients, because that is extremely important there too. As I stated, as an organization, we have to build asynchronous tools that benefit our patients both inside and outside of our organization. And I really think if we can continue to really focus on clear communications, rapid training, and early successes and continuous improvements of everything that we basically try to leverage within our overall organization, we will have successful outcomes.
Yeah. Michael, I think it's a great point, right? Like data and numbers are the universal language of love, right? It permeates every layer of the organization. And our prior CIO was, I would say, expert. And it doesn't have to be anything sophisticated, right? Like you can just pull out a general statistic. And we did this routinely, as we were going through our EHR implementation, routinely citing very basic statistics that demonstrated value, demonstrated awareness, demonstrated adoption, and demonstrated increasing proficiency in whatever, task, function, role, outcome we were, speaking to. And he was expert at keeping that simple, for a 45,000, plus another 12,000 physicians at our 2 Ivy League medical schools, like on point, concise, simple messaging, empirical messaging, irrefutable messaging.
So with that said, what creative adjustments to workforce composition, skills, employee types, and incentives are emerging to address current and future labor challenges?
I'll kick this one off. I spoke a little bit about Providence's co-caring model that we're trying to put out, and many organizations across the United States are trialing a virtual nursing model to put it out to figure out how it's going to assist us in the way we think differently and practice differently. And we know that the nursing shortage is going to be upon us by 2035. And how are we going to practice differently in order for us to survive? We know that there are many people who are coming up in the ranks that are wanting to either get into nursing or to medicine or somewhere in healthcare. And so an NAC spot is great for them to start to get to say, do they really like healthcare? And if so, what's driving their passion in what space? And so for us to purposely partner up a nurse with an NAC or nursing assistant to do that care on the floor, instead of having 1 or 2 nursing assistants for a 36-bed unit, you're having 1 for every nurse to do that. We're trying to bring LPNs back into the inpatient space. I can tell you it's very hard because our LPNs are not they can't adjust to the fast pace and the work that they have to do on the inpatient space. Now, I'm not going to say all of them can, because we have several success stories of LPNs who have done that, but we have more LPNs that have not been able to make it, only because, again, of the pace and the access that they have to get into the inpatient space these days. We're trying to think of just different ways and different options of doing things differently, to even increase our telesitter capacity in a different way, because we know we don't have enough sitters to sit by the bedside 1 for 1 all the time. So how do we increase that space to really look at things differently? again, as we all know, in all of our healthcare organizations, it doesn't have to be hospitals. It could be long-term care facilities or other places that manpower is always the issue. And when you have shortages of personnel, then that's where care suffers, right? So how do you do things different so that the care, the quality care that you're providing can stay to where it needs to be? So those are a few things that we're trying at Providence and Providence Swedish.
Yeah, great points, Pat. And yeah, to your point of workforce problems, right? If we didn't have workforce problems, we probably wouldn't have margin problems and having our CFOs in our ears all the time. So, you know, I think it's interesting how we have at Norton Healthcare have also shifted back to an LPN model. As a chief nurse, you probably know that can play havoc with a magnet journey as well. I would say that some of the other components we've done of late is partnering with local universities and school systems to become a shadow facility. We call them SNAP students, so that they're students and they're here and we're letting them shadow and get their feet wet in what the heck it looks like to be a nurse one day, or for that matter, what it looks like to be an MRI tech. And we're starting at the middle school age level now here locally to try to create some recruitment and pipeline and really build a culture and family, tradition here at Norton Healthcare. My daughter at IU now is physical therapy eventually. And hopefully Norton Healthcare can keep her living close to mom and dad. So those are things that we've really tried to hone in on, this Louisville or Louisville or whatever, however you pronounce it in your area. But yeah, thank you for kicking that off, Pat.
And we're dipping our toe in the water of all of those strategies as well. But Jason reminded me of all of our revenue cycle efforts as well. We started this innovation journey imagining all of the conversations at the time around waste in healthcare. We imagined that innovation was going to help us drive out that 30% waste that everybody was talking about. And that was our first problem statement that we gave ourselves, is how we were going to drive out 30% of our labor costs. Quickly, we realized that wasn't the problem statement we were trying to solve. What we're trying to solve is letting people do people work and letting innovation or technology do the work that it's best suited for. So we've modified our approach so that people savings aren't a requirement as a measure of success, but that realignment of people into more valuable, higher top of license work, all of those things. And we've done that in the revenue cycle in a couple of ways with automated attendance for all of our phone lines, with AI tools to help with record submission for authorization requirements, and continued stay review. Those elements help us then do the other thing that Jason said that I liked, was giving people time to imagine what the broader picture looks like, rather than worrying about what's going to needs to happen in the next 5 minutes. So trying to give people time to be people and be the innovators that they are in their own roles and tasks by using innovation.
I just pick up on Scott's revenue cycle theme here. We have a sort of couple of things. I think, to Scott's point, absolute FTE reduction, probably not the value statement you want to be publicizing. And so for our revenue cycle strategy, what we really say is that we are redefining and upskilling the role of the workforce in revenue cycle. And what we see here, we see essentially two roles emerging in the future of revenue cycle. And the first one is what I would consider relentless patient ambassadorship, right? We're still very much a physical, see, touch, feel kind of business. And I would say our revenue cycle, and particularly the front end of our revenue cycle, has historically been criticized for not having enough stewardship of the patient as a window to the organization, right? Because the first person you see in the emergency department, it might be a nurse, but it's probably a registrar, right? When they present at a clinic or for a radiology exam, these are the people they're seeing. And the truth be told, in 2 years, we're not registering patients anymore. So patient access as a function moves from mechanics to relentless customer service, right? So that's the first role that we see emerging. And so we're actively pursuing how to position 700, 800, 900 registrars across our 10 hospitals into that role. When you move further away from the point of care, the other role that we see emerging is what I would refer to as validation and audit, right? And so again, the mechanics of what our incumbent skill set staff do, they won't be doing in 2 to 5 years. They will not be calling insurance companies. They will not be scrolling on websites looking for claim status, which, by the way, has continued to be held up as the holy grail of automation and revenue cycle, despite its lack of utter value. But what the back office really becomes is, they really become change agents, right? Because they're the people that are seeing the outcomes, right? And they have to be able to validate those outcomes. They have to be able to create those aggressive feedback loops back upstream so that we can be in constant prevention mode, constant improvement mode. They also, by the way, will be validating the AI, right? Like that's a piece that needs to happen in the operation of the future. When you're applying all these intelligent technologies, every day, these algorithms, these bots, these machine learning apparatuses are learning on new data. And that new data may create bias. It may create false positives. You need that expertise to be able to say, this is not working. Let's step back. Let's reconfigure, let's adjust our training models, et cetera. So validation and audit is the other role that we see emerging in the future of revenue cycle. And so we're actively repositioning our staff from a stepwise fashion, like getting them acclimated to the concept of analytic and analysis. Right. And so we've put a number of positions in place to start orienting people to, roles of validation and audit.
Yeah, thank you, Jason. And thank you for adding some humor there for us all. We can all relate, I think, in some form. So the advent of generative AI signals a fundamental shift in the operational paradigm. What best practices have you established for defining a strategic purpose and identifying which areas to prioritize?
One thing when it comes to generative AI, I think one critical component here is really ensuring that this overall adoption really aligns with our core mission, really by improving patient care outcomes, by really while optimizing operational efficiencies in our overall healthcare organization. Some specific items that I have really kind of focused on was really trying to define strategic purpose through patient-centric goals. As I mentioned earlier in my discussion, I've always been focused around how do we build patient-centric technology initiatives that really enhance and improve clinical decision making, while with the utilization of AI really driving more of those diagnostic support tools to really help our physicians and nurses really better serve our overall community. What we did with the AI strategy that we put into place is we started the overall application in our radiology department. So we incorporated it into our mammography practice. What we wanted to do was the AI algorithm was supposed to basically look at specific dense breast tissues to really identify if there was any causes of potential breast cancer in a specific patient. The critical component here was that this specific AI algorithm was really helping the overall radiologist detect these specific items that the human eye couldn't catch. So again, there's always that pilot and test initiatives because, with AI, with new technology, there's always false positives. And really trying to work those out and really engage on the overall initiatives is really important. One critical element too that I've really learned with my overall success of implementing any new tools was really engaging the stakeholders early. I think by involving the key stakeholders early in any process has really been crucial to my success, because we were able to create multidisciplinary teams that really include clinicians, IT staff, and administrators to really assess the value of AI tools. Because again, we have to show value in any new initiatives that we put into place. Is it enhancing better patient care? Does it have a return of investment back to the organization? Does this really meet our overall technology initiatives, and does it meet the overall core boundaries and missions that we're trying to do moving forward? Also, too, what's really critical here is we have to balance innovation with data security and compliance. I think that's at times missed, especially with new AI algorithms coming into the overall organization. We've really established best practice around data governance to really ensure that any AI deployment is compliant with HIPAA and other regulatory standards that we basically have to meet as an organization. And this overall really includes rigorous testing and consistent monitoring of all our AI systems to really prevent vulnerabilities and to really ensure data privacy. Because at times, I think we forget about the importance of data security, the importance of where cybersecurity stands in your overall organizational strategy. My last item to really share is continuous learning and adaptation. I think the landscape of AI is really evolving, as we all know. And we have to set up a process for continuous learning and adoption towards any new initiatives that we do. And by regularly revisiting our AI strategy and staying abreast of new advancements, we can really pivot quick and scale up AI tools that really demonstrate proven results in improving patient care outcomes and operational efficiencies. That is really the important goal here. So in short, here at our facility, we made generative AI adoption purposeful. And that's a critical thing. That's the defined word, purposeful. By really focusing on patient-centric outcomes and starting with targeted pilots, involving the stakeholders at every step that we do, and ensuring that innovation is always balanced. It has to be balanced, ladies and gentlemen, with data security and regulatory compliance. This approach has really allowed us to realize AI benefits while really keeping our priorities firmly grounded in patient care. So that adoption around patient-centric outcomes has been one of the critical components of our overall successful factors there.
Yeah, thank you, Michael. Here at Norton Brownsboro Hospital, we're a comprehensive stroke center, and AI has really allowed us to become more efficient, more accurate, which is safer for the patient around our stroke program. So we're very engaged in the utilization of AI from that perspective. Contrary to our maybe hesitation from other radiology tools out there, I believe that if we continue to, and Michael, you hit on this, everybody's been hitting on this, we're really around every question, and that is around having the patient first. So becoming more accurate, right, in our evaluation and diagnoses, becoming more efficient at becoming more accurate, and then ultimately helping us become safer for the patient, I think is all of our goals. So it's interesting how we continue to dabble in AI in various areas, and it'll only get better as we become more confident and adopting that change. How is your organization utilizing AI, automation, and precision tools to foster innovation? I know we've been talking a lot about AI here, but this specific question really goes around the efficiency and growth. So what have you done to proactively engage your people and get in front of any resistance?
I have an example of that one as well. So we instituted AI monitoring in all of our operating rooms with both camera, AI-generated image for compliance of turnover times, clean cleaning protocols, those kinds of things. We also record all of the events during the operating room visit. That has led, after much weeping and gnashing of teeth from a variety of the cohort, that has led to us having top decile performance for turnover, for compliance on the timeout protocols and cleaning protocols, and allowed us to be then more efficient in our ORs by improving that turnover time. So all of our ORs now are performing at 90% or greater on-time start performance throughout the day. So that's been a huge turnaround for us using AI-generated information. A couple other places we use it. We do 100% coding review using an AI tool that allows us to look for missed clinical indicators that have documentation potential, missed documentation that was not coded already, and allows humans then to review that to make determinations. And then we like to pat ourselves on the back, and many of us have broken our arms patting ourselves on the back with our mortality score. We share either number 1 or number 2 position in mortality in the nation, mostly these days as a result of our reduced observed mortality. When we started using an AI tool to compare our patients and following their care path outside of our 4 walls, we were shocked to realize that our 30-day mortality actually was mid-pack for the nation, and so that created a lot of operational discussions in our clinical improvement committees on how we can improve 30-day mortality, which we are in many service lines have now gotten back into top decile performance.
Yes, Scott, I tell you, I had not seen sparkles in someone's eyes more so than Jason's when you talked about the AI tool for coding. That was impressive.
I would say, Jeremy, right? Like for everything we're talking about and all the transformation, right? Because we do autonomous coding for the ED, and we've been rolling it out for the better part of 2 years because it takes you 9 months to get the data, to interface correctly and everything. We are at, I would say, 50%-ish, maybe 55% of our emergency department claims are being autonomously coded with a level of accuracy that supersedes what a traditional human coder has done. And don't get me wrong, we'll take it, right? We'll take it. We'll take the reduced vendor expense. We're looking at some shared services with our university partners on the pro fee side. But 2 years, 50%, And, not all the AI's fault. I mean, ED is not like the beacon of, prescriptive documentation efficacy. So, I mean, there's probably some upstream things we got to solve there too. But yeah.
Great. And not to specifically call anyone out here, but Pat, just curiosity, do you guys use the Care Select tool within your ERs?
We don't right now. We continue to look at it, but right now we're not using it here.
Yeah, thank you. Sorry about that. All right. Well, Scott, thank you. You're definitely getting an A for going first. So in the face of fierce competition in the acquisition market, how are you prioritizing new and existing services, optimizing your outpatient footprint, and venturing into unconventional and alternative care delivery?
Well, I have a very short answer for this. I'm going to trump you, Scott. I got jealous. Sorry. It has been said by multiple people much higher on the totem pole than myself. We are an inpatient hospital. That is what our strategic plan is based on. We want to be the most comprehensive tertiary quaternary care hospital in the nation. We have very, very, very little revenue and at risk, through our managed care contracts. I think, we have an ACO, I think, that has 30,000 lives, which is, peanuts in the, just even in the New York metropolitan area. It's just, it's not part of our strategy right now. And we haven't partnered with, you know, a Walmart or an Amazon or some of these others, you know, new entrants, so to speak. So our focus is on curing heart failure.
Well, Jason, guys, everyone, I appreciate you all being on here with me. Thank you again for my sarcasm and entertainment and keeping us going. And at the end of the day, I wanted to leave with one note just around Louisville, and that is the concierge medicine growth and how a facility like ours, especially out here in the suburbs, is really trying to partner with those concierge groups to provide access for their patients, right? Our patients become spoiled. They don't want their MRI in a month. They want their MRI because their knee hurts tomorrow. I'll leave it with that. And I wanted to thank everybody else for watching today. This is going to be a Q&A, virtual Q&A, so please send your questions to connex@connexpartners.com, and then we'll get them answered, and Connex will post those on the Connex community. So again, guys, thank you. It's a pleasure meeting you. I feel like, Jason, I've met you before somewhere along the line. And thank you, AJ, Ray, and the group for connecting us today.
Thanks for moderating, Jeremy.
Thank you.
Thanks.